point. Now, I want to get back to the question, Jeff, you said you talked about all these opportunities, and certainly from also the comments that Paul and Bobby had about there are lots of questions we need answers to in the policy space that all of you can contribute. So where are we going to get this, how are we going to get this research funded in this time of budget constraints and the discretionary side? What are the opportunities? And we're going to hear later today from one of those opportunities, Dr. Joe Selby, from the newest player on the block.
That's first on my list.
But Jeff, do you want to comment on that? And
yes, but before I just want to agree with Paul about return on investment and that being incredibly important. And there's a research task associated with that, which is it's very hard in public health to do return on investment research because people do not collect data in consistent ways, and because we like to think that we're doing God's work, so we never collect cost data, and we actually need that cost data in order to actually know whether it's a worthwhile investment. That's a good, and I'd also underscore Bobby's point about do we have the right kind of workforce? And what I know that in the teaching that I do at a school of public health, that we're, the very things that I say in my advocacy role that public health needs to be doing, we're not training our students to do those things. And so we have to close that gap. I would also say that rather than bringing your research to policymakers after it is done,
right.
I think there's a real value to engaging policymakers before you even start down the path of designing your research. Because if you have a choice between two questions or the design of your study, and one will be relevant to an important policymaker and another will be, oh, that's interesting, go for the one that will really make a difference. So how do we pay for this? I mean, that's a real challenge. I think, the combination of difficult times and very new demands from our system does indeed provide an opportunity. So I'll let people gang up on Joe tonight about PCORI, but we do have to think about comparative effectiveness, about not just what happens within the four walls of a clinic, but if we're really thinking about what's good, if we're patient-centered, then it's what's good for the patient wherever that service may be delivered. And so when we're thinking about prevention, whether it's primary or secondary prevention, we need to be able to see some of those head-to-head studies of what a public health system may be doing or a community-based organization may be doing, as opposed to what might happen in the clinical system. Paul mentioned the need for a waiver around asthma. That's actually changing under the Essential Health Benefits rule that has been proposed for Medicaid. Community-based providers will be allowed to deliver some of those services. And so that provides a whole new opening for educating Medicaid directors about the good research, the evidence that's out there for some of these non-clinical interventions, and then training clinicians to take advantage of those kinds of things. So there's a whole new opportunity there. So obviously, PCORI is the new money on the block, but that's not the only thing. We have to be honest about how we are now spending our public health resources, and particularly at CDC, and I would say also at AHRQ to the degree that they have resources, and really thinking about what are the questions that are needed, and can we repurpose some of the existing dollars? Yes, it is a zero-sum game, but some of the questions we're asking are no longer relevant, and we should change. It is, I feel very sorry for the folks at NIH that they suffered a sequester, but there's also a belief at NIH that once you are getting your grant, somehow this is a lifetime entitlement. And it's not, and it should not be, and we should all still be competing to make sure that what we are doing is relevant. And, whether we like it or, I would disagree with Paul. I actually think this administration is committed to public health, understands public health, but it also believes public health has to change, and it has to change for two reasons. One, because some of the things public health delivers are now going to be covered by health insurance, and if there's a public health role, we have to find different ways of financing it, and then we need to come up with, through the healthcare financing system, and then we have dollars that we can repurpose to support this kind of research and other kinds of activities. If we don't acknowledge the need to repurpose and come up with an agenda for how it gets repurposed, then it does go away. The risk of not acknowledging repurposing and coming up with that agenda is the real risk, as opposed to a lack of commitment, I think, to understanding at least these very difficult questions for public health. And we do have to be willing to make change rapidly. This is an administration that is overseeing, for better or, everyone said, oh, if only the Affordable Care Act had been fully implemented by the election, things would have been so much better. Just think how hard it's been to do in 3.5 years, but they are doing it, and they're changing the entire healthcare delivery system and financing system in 3.5 years. We've had 3.5 years of notice in public health that the world is changing. And so we need to be getting on that bandwagon of rapid change and rapid adaptation to a new world.
And measuring the impact of that
Absolutely.
Adaptation. And I would just add to all of the comments that you've made that I think it's important for those of you in PHSSR to think about also, as you frame your research question, what if the findings actually support that another agency other than governmental public health should be delivering a service? Be clear in your own mind where along that continuum of evidence versus advocacy you are yourselves. Because I think you have to be self-aware and honest about yourselves in terms of the credibility you will then bring to the table with a policymaker if you're willing to bring forward the answers regardless of what the answer is in terms of its fitting into a preconceived advocacy agenda. So I just wanted to make that comment.
Lisa,
so,
if I can...
please.
I have to respond. Jeff, if I had said that this administration doesn't support public health, then I misspoke. I didn't intend to say that. What I do want to say, though, is there's times there are practical implications to policy decisions that they need help on, that they can't see at that level. So I just don't want to let that stand.
Good, Paul.
I do want to build on something you said, though, that there is an opportunity in many ways as things get included, like you mentioned, asthma abatement into health insurance, that is potentially an opportunity. It is also potentially a threat. In that one state that is a largely rural state had been running for about 20 years the home visiting program in that state. And as an extremely rural, lack of other providers, so it happened to be the state health agency with their local representation that did these visits. When the Medicaid in that state was then, quote, privatized and turned into managed Medicaid, all that money went to the managed Medicaid agencies who hadn't thought about how were they going to do home visiting. So now you had a program, statewide program, essentially defunded. Now here's where I think we need you. When I talked to that health official, and I used to work in the insurance world, they said, well, pretend I'm one of these insurance executives, present me your program. Well, here's what we did, blah, 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 blah. And I'm like, okay, well, how many women, what were the results, what were the impacts on the birth outcomes? We don't have that data.
Right.
And I said, get out of my office. So if we're gonna be up there competing, if health agencies wanna compete, and in some cases they are the best provider of these services, they need to understand they're competing in a world that's a full risk world. If we hired a commercial vendor to do home visiting, they would have been at full risk for their fees to hit the targets we set. So we really need your help in both training people how to do that kind of hard evaluation of outcomes and dollars, but also get in there and study some of these programs. If they really aren't any good, we should stop doing them and repurpose that money. If they are good, we need to show that they're good, but we do not have the data like that at all in public health, and we need it. And I would say the same thing probably goes for the lead abatement programs and many other programs we're running. Most of our evaluation has been for justification of grants and grant compliance. It's not been to drive quality and show results. So we need a lot of help in that area.
Great.
I think that, back to the question of where's the money, I think that generally speaking, it's probably in 3 different places, and that it's useful to, again, visit each of those places. The first is that it's available, I think, in businesses, local businesses, national businesses, medical care businesses, people who are being affected and have employees who are being affected by some of the changes that are coming about. And once again, getting to know business people who are facing huge changes in their own costs, There is funding available either directly through businesses or through the foundations that businesses have created. A second is obviously government, and we'll hear more about that tonight, but all of you are, I'm sure, well familiar with the normal sources of governmental funding for research. But the other is philanthropy. While we tend, many of us, and many of us probably in this room, are funded by one or two philanthropies. There are family foundations and conversion foundations that exist in many states that are also potential sources of funding. And I think would like to hear the ideas that you have about the research that you may be interested in, and also might be interested in talking with you about the research that they would like to have done. And I would suggest also that if you're in an academic environment, the ones that I'm familiar with have, many of them, have very strong development arms who are raising money for the schools or universities, who are talking with people who are thinking about what they will do with their own assets and their own investments going forward, and who might be interested in knowing something about the areas that you're interested in, or quite frankly, even directly funding you. I did some work with a nonprofit organization that, in essence, solicited, identified families with wealth that had family members that had particular kinds of problems, and went to talk with them personally about the kinds of research that either they might be interested in or the kinds of research that might be helpful to them. My guess is that there are many more families, family foundations and families out there to whom you might reach through your development arms of your universities or other organizations, and that those development organizations may not know about the work that you're doing. So invite the development officer out for lunch, offer to take them out for a beer, see what they have to say and what their process is all about, and see whether they might have a family who might be interested in the research that you're doing, or might know of someone who might know a family that would be interested.
Great. Thank you, Bobby.